for my last talk, the organizers gave me the daunting task to talk about blood pressure targets in all sorts of brain injuries in 15 minutes. So I hope I manage and deliver something that is somehow satisfying to you. Blood pressure targets in neurocritical care is mainly or perceived as a balance between two things. On the one hand, there's the hypoperfusion of the brain. On the other hand, there's the fear that hyperperfusion may lead to brain edema, localized around a lesion, or global brain edema. And we've seen that even from the earliest discussion when we talk about cerebral perfusion pressure, where you had the big discussions between the Rosner principle fans, and then on the other hand, people who were concerned that too high cerebral perfusion pressure would increase brain edema or swelling around trauma. Now that has then been studied in this, let's say, legendary trial, meanwhile, in 99, published by Claudia Robertson and her group, who compared the two approaches, who compared the protocol that was more ICP targeted, which was then called the Swedish or Lund approach, and something that was more targeting CBF and CPP, and actually found no difference between both strategies. So this translated then into guidelines, and so the guidelines say, well, it is recommended to monitor cerebral perfusion pressure, and it's somehow recommended to have a cerebral perfusion pressure between 60 and 70. And I think the guidelines, they were quite prudent, because they say whether 60 or 70 is the threshold may depend on the autoregulatory status. So I think if you monitor autoregulation, as I will show right now, I think you can go outside this range, and I also challenge people to keep a CPP stable at 60 or 70, and whether you can actually do that. And so how do you do this? Fluids and pressors, which is, of course, quite obvious. So cerebrovascular autoregulation, I think we all know the physiology, or we think we know the physiology about this. This is actually a study that was based on a number of databases from a number of different settings, then grouped together into one graph. I would doubt that this paper would get published nowadays, but from that we have this classic cerebrovascular autoregulation graph, or the Lassen curve, but it's actually 11 groups of subjects from 7 totally different studies. And we don't really know what the autoregulatory curve looks like right now. This is experimental work from our group, where we made a cranial window in a piglet and then looked at the actual diameter of the pile arteries, which is believed to be the main site of resistance for cerebrovascular autoregulation. And we looked at flow, speed, and diameter independently from each other. And what we actually discovered in these piglets was that autoregulation does not have a classical triphasic curve, but it's actually quadriphasic. And in particular, the upper level of autoregulation is quite hard to detect, because there might be 2 breakpoints. Which means, if you translate that to the clinical situation, that it's easier to detect the lower level of autoregulation than the upper level, and that you have to be indeed prudent when you push up blood pressures, that you might get a breakthrough of one of these levels while not detecting it. Now, if autoregulation is such an important thing, you would think that we all agree on what it is at the bedside. This is a report of a consensus conference that we did in Leuven in 2019, when we had the ICP conference there, and we had all the experts on ICP in our city. So we had 25 experts there. We made 77 statements. There was consensus that autoregulation is important, that it's dynamic, which means that it can change within a patient and between patients, that it associates with outcome when it's impaired, that there is probably not a universal CPP threshold, but we actually do not know how to measure autoregulation at the bedside, nor do we know how to implement the information in our management protocols. And so the current methods that we use are insufficiently understood. Information may be helpful, but it's still subordinate to what we know that we measure. And the tolerance of secondary insults is impaired by impaired cerebrovascular autoregulation. There's one trial where we try to compare a fixed CPP threshold versus a dynamic threshold, which is a cogitate trial, was not powered for outcome, was just powered to see whether it's actually feasible to target a dynamic CPP threshold by PRX. And the results were quite disappointing, I must say, because it was only possible to get within that targeted dynamic CPP range in less than half of the cases. There was a trend towards lower mortality in the intervention group, but of course we cannot have any conclusions there because the study was not powered for that and it was also not significant. What we did see that if you target this dynamic CPP value, that you tend to go for higher CPPs. Now, how can we do that in practice? How can we implement autoregulation in practice? Maybe the most practical thing is just you change blood pressure and you see what happens in your neuromonitoring signal. If you see that you improve things, you might choose for this new threshold. If you see that things worsen, you might want to go back to the previous threshold. And that is called a MAP challenge or a blood pressure challenge, which is also in the CIBIC guidelines as well. So far for TBI. Let's go to other brain injuries, which is stroke. Blood pressure targets. What are blood pressure targets in ischemic stroke, in subarachnoid hemorrhage, in intracerebral hemorrhage? Well, actually in ischemic stroke and subarachnoid, it's quite complex, which means we don't have good data to give you recommendations. In ICH, it's more straightforward and the guidelines are more consistent. So in ICH, we have, of course, the INTERACT-2 trial, which I think most of you will know, where thousands of patients were randomized to intensive treatment to reduce blood pressure to 140 within an hour and maintain that blood pressure for 7 days versus only treating blood pressure when it is over 180. And the effect was that there was a borderline non-significant trend for death and severe disability, and there was a reduction in rate of hematoma growth. There were post-hoc analysis of these trials as well, and it seemed that not only the maximum blood pressure and the average blood pressure, but also the variability of blood pressure seemed to predict poor outcome, which probably means that if you reduce blood pressure, that it's important to keep it stable at that level. INTERACT-2 was followed by ATTACH-2, which is a trial that actually compared two strict thresholds. So they compared go below 140, so 110 to 139 to 140, 179, and there was no increase so there was no better outcome here, but there were more renal adverse events, so more acute kidney injury within the first 7 days in the intervention groups, which of course shows that you have to be cautious in reducing blood pressure aggressively in these patients who probably have chronic hypertension already and whose renal autoregulation might be different. Now, what is very interesting, and is what José Suárez did in this paper, is actually, if you want to interpret the two trials, you should not only look at what they aimed for, but also what they actually did. What you can see here is actually that the control group in ATTACH-2 actually was very close to the intervention group in INTERACT. So if you devise guidelines, it's important to think of that. And also in a post hoc analysis of ATTACH, what you could see is that if you are very early in reduced, like if you do it within the first 2 hours and you can be consistent in that you do have a significant effect on hematoma growth, functional independence, and good outcome. So maybe we need to be even more aggressive and earlier and be more consistent than what was done in these trials. And so, as I said, the guidelines are quite consistent. There's some nuance difference, but I don't think that the difference between 150 or 140 will make much of a difference in clinical practice. Now, Meanwhile, there's been confirmation studies. Meanwhile, Interact-2 has been published, Interact-3, sorry, has been published this year. Low and middle income countries and one high income country, which was Chile, and they tested a bundle which included blood pressure control, but also glucose control, also fever treatment, and also rapid reversal of anticoagulation. And in this setting of mainly low and middle income countries, this grouped intervention did show to improve 6-month outcome. And Interact-4 is also ongoing, where they're going to try to reduce blood pressure even more early in the ambulance already. Subarachnoid hemorrhage, very briefly, because I only have 4 minutes left. What do we do about early blood pressure control before clipping and coiling within the first 24-48 hours? We don't know. We only have observational data. Probably makes sense to reduce blood pressure to 180. And if you're an American, maybe to 160, because those are the American Heart Association guidelines. In the subacute phase, we used to do Triple H, but Triple H is something that is no longer recommended. And of the 3 components, it's only the hypertension that will increase cerebral blood pressure cerebral blood flow. So if you want to do something in the subacute phase, it's probably the blood pressure that you want to manipulate. And then we have, of course, the Himalaya study, which most of you know, which unfortunately after 6 years was only able to recruit 41 patients, which shows you how difficult it is to recruit these patients with DCI in clinical trials. And of course, in this hugely underpowered study, there was no effect on outcome, but inducing hypertension has systemic side effects, which is not a surprise. Okay, and then I will rush to ischemic stroke. I think this is a complex slide, but I will explain in the next, in my last 4 slides what it's about. So what do we do with ischemic stroke? We actually do not know very well. So there's the CAT is the Chinese trial that with a complex intervention of a rate of reducing blood pressure by 10 to 25% in the first 24 hours, and then go down to less than 140 or a diastolic less than 90 within 7 days, and maintain that during hospitalization versus a control group that had no antihypertensive treatment. And as you can see here, even while the intervention was successful in reducing blood pressure, there was no effect on outcome. Enchanted trial, where they lowered the blood pressure to achieve and maintain a blood pressure of 130 to 140 versus staying below 180. Here as well, intervention was successful in reducing the blood pressure. There was no effect in 90 days outcome, but there were fewer intracranial hemorrhages in the intervention group. And so the guidelines on ischemic stroke are, they're a bit more diverse. Also, some of them may be only differ. They may only differ in the details. I know this is a complex slide, but I will, in my concluding slide, you will see what the recommendations are. In a post-hoc analysis of the Enchanted trial, they found out that actually it does make sense to try to reduce blood pressure after an ischemic stroke, and that actually every 10 millimeters of mercury of systolic blood pressure reduction, as long as you stay above 110, 120, can reduce the odds of unfavorable outcome. And that variability here as well, varying blood pressure, as we saw in the other pathologies as well, associates with poor outcome. I know I presented you with a lot of data, I warned you, but it was a huge task. But let's come to a conclusion that may be something that is useful. So blood pressure targets in TBI, I think we will probably start with the recommended, and this is not MAP, but CPP, by the way, sorry, this is a typo, 60, 70 CPP, and then maybe individualize based on autoregulation, do your MAP challenges and see whether you can improve things. And if you have neuro monitoring or PRX monitoring, could be useful. In ICH, you will want to reduce to 140 in the first 24 hours. Beyond 24 hours, we don't know yet. Maybe you want to go ultra early and try to do this in 2 hours, but what you also want to do is avoid variability here. SAH, lack of clinical trials, so before securing the aneurysm, you just reduce to below 180. Triple H no longer recommended. I think most of you know that. And if there's delayed ischemia, you will targetedly increase blood pressure based on symptoms, based on monitoring if the patient is unconscious, or based on neuroimaging to treat this DCI. And then ischemic stroke, you treat blood pressure in the early phase only when it's very high. After IV thrombolytic therapy, after thrombectomy, you'd want to be a bit stricter. And maybe after IV thrombolysis, early, rapid and sustained reduction to levels below 140 is something that can be considered. So apologies for the multitude of data, and with this I would like to conclude.
Thank you so much, Geert, for such a comprehensive review of a formidable topic that could have had a two-day conference to itself. If anybody has any questions, please feel free to come to the mic. Meanwhile, I have one question from the chat. Again, a difficult population. What would you recommend for blood pressure targets when you have vasospasm after traumatic brain injury? Yeah, that's a difficult topic indeed. So the question is, what is vasospasm after traumatic brain injury? That's one thing. Is it just an angiographic phenomenon? Is it edema and compression? So what is it? I don't think that there's a straight answer for that. And the problem is, of course, TBI is heterogeneous between populations, but also within the brain. But we can only apply one blood pressure. So we sometimes have to choose, okay, what are we going to aim for? Are we going to aim for healthy brain? Is that where we put our monitoring? Do we put it in the penumbra of lesions? And I don't think that there's a clear answer to that. I think globally, what I would assume that you could do is that wherever you decide to, I assume you put your monitor in the site of interest for you, you try to increase blood pressure with something that is reversible, like a vasopressor. You look at the new value and you look at your neuromonitoring data. That can be TCD, that can be PBTR2, and you see whether you improve things and whether the ICP, which is probably your safety signal, doesn't increase here. If things worsen, please go back. And also, once you're up and once you're high with blood pressure, you should consider reducing as well as a test. So MAP challenge can go in both ways. It can be an increase, but also a decrease. But to be honest, there's no clear answer, universal answer to that very difficult question. I think, as you said in your slides, it's complex. Yeah. Marcus?
Any thoughts on the preferred drug? Are there any evidence at all on that?
Most of the studies now will use nicardipine, which is convenient because you can steer it. It's very elegant to work with. Older studies have used urapidil, some of the older trials. In view of what we heard on cardiac dysfunction, I would be very cautious in using beta blockers and all these drugs. But I think nicardipine is the most convenient drug. It's probably why it's used. It doesn't say that it's the best drug. Of course, in subarachnoid, we already have nimodipine, which already has that effect of blood pressure reduction. And sometimes nimodipine and nicardipine is combined in some centers. I don't know if that makes any sense. But in the subarachnoid, you already, in most cases, you have enough with your nimodipine.
Hi, hello, Pablo from Spain. So I want to ask, controlling arterial pressure on those kind of patients, how should we monitor the pressure, invasively, non-invasively, how often, if non-invasively, and where should we admit that patient? HDUs or intensive care always, sometimes yes, sometimes not? Yeah, indeed, you're right. It's a good question. I think if these patients are admitted to the ICU, these are, in most cases, also the ischemic stroke, they only rarely get admitted to the ICU, at least in my center. So these are very severe cases, often comatose. I think you would do an arterial line when they're admitted to the ICU always. Of course, a lot of these patients are admitted to stroke units. I don't work in a stroke unit. At least in our stroke unit, it's not possible to have an invasive heart line because the nurses cannot work with it. So the neurologist will have to work with non-invasive pressures. But if you admit them to the ICU, I think for many reasons you would put in an heart line, also because you want to take blood gases, you want to control ventilation. There's a lot more that you want to control with
in these very severe group of patients.
Matthew, we'll take one more question, then we'll go to the next speaker.
Geert, thanks for the overview. Are we sure that the observation that when we increase blood pressure, for instance, in patients with SAH with vasospasm, these patients can improve somewhat? So they have arousal, they become more awake, or are we sure that it's a blood flow improvement that causes that? Because norepinephrine, for instance, is also a neurotransmitter that may increase arousal.
Yeah. Yeah, that's true. No, you cannot know. I wouldn't know how you would know that, so I don't think you can do that. But I mean, I've seen in these cases, the best monitor is the patient. So the ideal situation is a patient who is not sedated. And I mean, for instance, a patient who develops a new neurological deficit, and I see these cases a couple of times per year where you increase blood pressure, 5-10 millimeters of mercury, and the symptoms disappear or attenuate. And so it's clear that the intervention, whether it's giving the norepinephrine or raising blood pressure, but I do think it's raising the blood pressure, because you can often see changes in imaging as well, or changes in your TCD signal as well. So I do think is the hemodynamic effect, but at least the intervention in many of these patients work. What is less clear is in the patients who are not conscious, where you only rely on imaging or only rely on your monitoring, on your TCD, whether you're actually doing something. I don't know the answer to that, to be honest.
Okay.